Regional anesthesia, spinal and epidural anesthesia. What is meant by regional anesthesia? Regional anesthesia means injecting the anesthetic drug around the peripheral nerve at any point from the beginning of spinal cord till the sensory organ. So, in regional anesthesia, we have no CNS depression and the patient is fully conscious. Regional anesthetic techniques categorized as spinal anesthesia and epidural and peripheral nerve blocks. In spinal anesthesia, we inject the local anesthetic drug in the subarachnoid space, commonly at L3, L4. To review the anatomy of spinal cord. The spinal cord begins from the foramen magnum till L1, L2 in adults and L3 in children. The spinal cord is also protected by 3 layers of covering called the meninges. They are the dura mater, arachnoid mater, and pia mater. The spinal cord, as I said, usually ends at the level of L1, L2 in adults and L3 in children. So, dural puncture above these levels is associated with risk of damage to the spinal cord, so it is best to avoid the injection in higher levels. So an important landmark to remember is that a line joining the top of the 2 iliac crusts is at level of L4 or L4, L5. As we see, this is the commonest position for spinal anesthesia, which is the setting position. As we see also, this is the line joining the 2 iliac crusts of the patients. Other positions for spinal anesthesia include lateral and prone position. Again, spinal anesthesia include the injection in the spine in the subarachnoid space, injecting the drug in the subarachnoid space in the CSF. So the drug is circulating around the spinal cord and spinal nerves. In epidural anesthesia, we inject the drug in the epidural space. No dural puncture as in spinal anesthesia. When we introduce spinal needle, we puncture supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, subarachnoid space. Again, layers which are pierced by spinal needle, skin, subcutaneous fat, supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura, then the subarachnoid. What are the indications of spinal anesthesia? The subarachnoid block can be used to provide surgical anesthesia for all procedures carried in the lower half of the body. So we can use in lower limb surgery, pelvis surgery, genital surgery, perineum surgery, urological procedures. Any procedure for the lower half of the body. Spinal anesthesia have a lot of advantages over general anesthesia, including low cost, much better patient satisfaction, fewer respiratory complications, patent airway, also can be used safely in diabetic patients, elderly patients. Spinal anesthesia produces profound muscle relaxation and can be used to decrease blood loss during this operation and produces prolonged post-operative pain relief. It is ideal for procedures in the lower half of the body. Spinal anesthesia reduces full and complete anesthesia, and the block can be prolonged to produce a pain-free post-operative period. Spinal anesthesia can be an alternative for general anesthesia in poor risky patients, especially in patients with difficult airway and respiratory diseases. Spinal anesthesia reduces contracted bowel and blunt surgical response to surgery. What are the contraindications for spinal anesthesia? We can divide contraindications for spinal anesthesia to absolute contraindications and relative contraindications. Absolute contraindications like sepsis, bacteremia, skin infection at site of injection, severe hypovolemia, coagulopathy, increased intracranial pressure, and lack of patient consent. Some patients refuse spinal anesthesia due to anxiety. Relative contraindications like peripheral neuropathy, uncooperative patients, psychosis or emotional instability, many dose heparin or aspirin or anticoagulants, demyelinating CNS diseases, certain cardiac lesions, prolonged surgery or surgery of uncertain duration, infants and younger children due to lack of experience. What are the drugs used in spinal anesthesia? In spinal anesthesia and epidural anesthesia, we use local anesthetic drugs. Local anesthetics produce a transient and reversible loss of sensation without loss of consciousness, so the process is usually reversible. Local anesthetics which are used for spinal anesthesia can be divided according to the specific gravity of the drug in relation to the specific gravity of CSF into hyperbaric, hypobaric, isobaric. Hyperbaric heavier drugs, hypobaric lighter drugs, or the same specific gravity as the CSF. In hyperbaric drugs, they tend to spread below the level of injection, while isobaric drugs are not influenced in this way. Again, in horizontal spinal position, as we see, we have two curvature. Hyperbaric local anesthetic drugs injected at the height of lumbar lordosis flow down lumbar lordosis to pull in the sacrum, as we see, and in the thoracic kyphosis. This pulling in the thoracic kyphosis is thought to explain the fact that hyperbaric drugs produce blocks with average height T4, T6. Some important physiological factors we should remember that cardiac accelerator fibers arises from T1 to T4. Block of these fibers causes bradycardia and decrease in cardiac contractility. Vasomotor fibers arises from T5L1. These fibers determine the vasomotor tone. Blockage of this fiber causes vasodilation. Sympathetic outflow arises from T5L1. So, block of sympathetic outflow leads to increase in the vagal tone and small contracted gut with active peristalsis. Problems with spinal cord: no block at all, failure of spinal, block in one side, block is not high enough, inappropriate block يعني. Block is too high, nausea, vomiting, shivering, difficulty to give spinal, as in the spinal cord deformities and aging, hypotension, total spinal anesthesia, problems with long surgery, more than 2 hours. Sometimes we need sedations with spinal for psychological aspects. Post-dural puncture headache, risk of infection, risk of hematoma, coda equina syndrome, and lastly urinary retention. In another way, we can divide complications in immediate complications like hypotension, total spinal block, systemic toxicity, and delayed complications like post-dural puncture headache, epidural hematoma, focal neurological damage, and bacterial meninges. Treatment of spinal hypotension. Hypotension in spinal anesthesia is due to vasodilation. As I said before, vasodilation leads to hypotension. This hypotension can be treated with vasoconstrictor drugs. Oxygen should be applied to the patients, raising the legs to increase the venous return of, and the use of vasopressors like ephedrine, phenylephrine, and if the hypotension is profound, we can use noradrenaline or adrenaline. Another common complication to be heard from spinal anesthesia is headache, post-dural puncture headache. This headache can begin within hours and may last for a week or more. It is postural, being made worse by standing or even raising the head, and relieved by lying down. This headache is often occipital and may be associated with stiff neck, nausea, vomiting, dizziness, photophobia. And it is more common in young females, especially in obstetric patients. What is the cause of post-dural puncture headache? It is thought to be caused by the continuing loss of CSF through the hole made in the dura. As I said, in spinal anesthesia, we puncture the dura. If the dural hole is large, it leads to loss of CSF and traction on the meninges, causing headache. So, the incidence of headache is related to the size of the needle. So, if we use small spinal needles, we will decrease the incidence of post-spinal headache. Another way to decrease the incidence of post-dural puncture headache is to puncture the dura parallel to the axis of the fibers. So the bevel of the spinal needle should be parallel to the long axis of the spine to separate dural fibers, not to cut them. Treatment includes lying down, encourage the patient to drink a lot of fluids, analgesia, caffeine-containing drinks to produce vasoconstriction, and in severe cases, which is rarely, we use epidural blood patch, which means injecting the patient's own blood into the epidural space. This blood will be clotted and seal the hole and prevent further leakage of CSF. Epidural anesthesia. As we said before, in epidural anesthesia we inject the local anesthetic drug in the epidural space, not in the subarachnoid space. To remember epidural anesthesia, I will compare it with spinal anesthesia. In spinal anesthesia, we inject the local anesthetic drug in the CSF. In epidural anesthesia, we inject the local anesthetic drug in the epidural space. In spinal anesthesia, we doesn't use a catheter. In epidural anesthesia, we use a catheter to inject the drug. Spinal anesthesia can be used for procedures of lower limb and pelvic surgery. Epidural anesthesia can be used for both lower limb surgeries and pelvic surgeries and also thoracic surgeries. In epidural anesthesia, the onset of block is usually delayed up to 30 minutes. In spinal anesthesia, we have an immediate block within 5 minutes. The duration of epidural block can be extended up to 48 hours. In spinal anesthesia, the duration is limited only 90 minutes. The efficacy of block in epidural anesthesia may be incomplete, but in spinal anesthesia usually complete. In epidural anesthesia, we use large volumes of the drugs like of local anesthetics. We use huge volumes, so there is risk of local anesthetic systemic toxicity. But in spinal anesthesia, we use small amount of the drug, so less risk. In epidural anesthesia, the technique is more difficult, and it uses a catheter, and we can use multiple and repeated top-up doses. In spinal anesthesia, the technique is more easier than epidural anesthesia, and it is a single shot, only one shot, and no top-up doses. A headache is not present in epidural anesthesia except if in case of accidental dural puncture. In spinal anesthesia, both dural and puncture headache can occur. Hypotension is uncommon in epidural anesthesia, and it is universal for all cases of spinal anesthesia. Spinal anesthesia causes complete block for both motor, sensory, and autonomic fibers. In epidural anesthesia, we can select, so we can use sensory fibers without motor relaxation, so we can provide analgesia without muscle paralysis, and it can be used for post-operative analgesia. So epidural anesthesia with the advantages of the using a catheter for post-operative pain relief up to 48 hours. I hope this lecture can provide some information about regional anesthesia you may need, and thank you.